Welcome to part 3 on our video learning module on the acute abdomen. This is Dr. Kim, and in this podcast, we'll discuss the phenomenon of perforation. What images run through your mind when you think about perforation in the abdomen? Most of us picture a medical emergency. We envision a deathly ill patient with a rigid abdomen who's being rushed into the operating room for an emergent procedure. The chest x-ray on the left shows the classic findings of free air under the diaphragm, and the vital signs on the right suggest that the person is in septic shock as evidenced by the hypotension and tachycardia. Although this dramatic depiction is accurate for many patients, what you need to understand is that not all perforations are this devastating. Not all perforations are the same. The learning goal for this session is for you to recognize that the phenomenon of a hollow viscous perforation in the abdomen presents along a spectrum that ranges from mild infection to frank sepsis and death. How a patient does depends on where they lie along the spectrum of contained versus free perforation. Let's start by reviewing the most common causes of perforation in the abdomen and the steps that lead to perforation in these disease processes. Perforated acute appendicitis, diverticulitis, and cholecystitis develop from obstruction of blind end luminal structure that creates a compartment-like syndrome where there is compromised perfusion at the level of the capillary and the venous outflow. This eventually leads to worsening of infection and necrosis and eventually perforation. In small bowel obstruction and in many cases of diverticulitis, the ischemia actually occurs related to a focal pressure from an adhesive band or a fecalith, and this leads to infection, necrosis, and perforation. Perforated peptic ulcer is caused by erosion of the duodenal and gastric wall through acid-mediated damage. And then for ischemic bowel, there's direct compromise of the blood supply that leads to necrosis and perforation. Among the disease process discussed in the previous slide, the likelihood of perforation of being either free or contained varies. For example, bowel perforation from small bowel obstruction is almost always free and uncontained, as are perforations from peptic ulcer disease. Free perforation, on the other hand, from diverticulitis occur only in about 10% of the cases, while free perforation and acute appendicitis are rare, and these perforated appendicitis usually present with a contained abscess or phlegmon. One of the goals of this podcast is to get you to think about why these patterns of perforation occur and create a coherent narrative. And here's a schematic that might be familiar to you. It is known as the epidemiologic triad, and it's used to describe three main factors that contribute to the prevalence or the severity of a disease process. First is the virulence. In our case, we can ask the question, what is the source, and more importantly, what is the volume of the contamination? Is it stool? Is it bile? Is it gastric content? Is there necrotic tissue? How much infected material has been spilled and continues to be spilled into the abdominal cavity? Second is the environment. Where is the location of perforation? Within the peritoneal cavity, which is open, or is it in the retroperitoneum or down in the pelvis where the space is more confined? And lastly, and just as important, is how capable is the individual of mounting a defense? Are they in good health? What is their nutritional status? And do they have any problems with their immune system? Since we've already discussed the pathophysiology of the various acute abdominal disease processes, I'd like to focus more on the all-important host defense mechanism in the abdomen. With the breach in the mucosal defense layer, the body's immune response systems become activated. PMNs and macrophages secrete various factors to increase blood flow and recruit additional resources in the fight against the infecting agents. This slide illustrates the microscopic response. This was an experiment in which Staphylococcus was injected into the peritoneal lining of mice. The number on the left of each picture indicates the days from the injection. So on the first day, there's already an active inflammatory response with PMNs which surrounds the bacteria. Over the ensuing days, there's eventually a formation of a fibrinous and a fibrotic wall that starts to form as additional macrophages and fibroblasts enter the scene. This is an excellent example of containment of a limited source of contamination, and this is also an example of an abscess formation. Most of you are already familiar with the microscopic view of the body's immune response. What I'd like to add to your understanding is the macroscopic picture of the body's defense mechanisms. With continuing inflammation, there's production of fibrinous exudate, which almost acts like a sticky glue that draws in the surrounding bowel and omentum and tries to actually physically seal off the contamination itself. This video shows an example of a perforated appendicitis resulting in a large pelvic abscess. The body has been able to physically wall off the bacteria to prevent diffuse peritonitis. As you can see with the scan, as we scan down, you'll see the fecalith on the right lower quadrant and this very large abscess in the pelvis. And this procedure is done laparoscopically, as you will see. And what I want you to focus on is how sticky. There is no free pus within the abdomen. You're starting to see the free pus once we get into the cavity. You can see that the small bowel wall is very, very stuck to the abdominal wall there. And then here we go, here the surgeon is getting into the pocket of abscess, or that large fluid collection that you saw on the CT scan. It is starting to be opened up and it is being drained. I hope watching this video clip has opened your eyes to how the body tries to defend itself against gross contamination, at least in the abdomen. You might ask yourself, if the contamination was already contained successfully, then why did this patient need an operation? What you have to realize is that abscess formation is an effective way for the body to physically seal off bacteria and other contaminants. However, at the microscopic level, it's not always a perfect system. The bacteria can still breach the walls of the abscess and enter the bloodstream. This picture shows infiltration of bacteria into the abscess wall. The letter A designates the center of the abscess and C is the periphery. And as you can see, there are capillaries around the letter B through which the bacteria can escape. And when they escape, they can lead to septic shock and other untoward effects of bacteremia. So for large volume of contamination, abscess formation may only help to temporize the situation, and additional treatment with particularly reduction of the volume and possibly source control of the contaminant may be required, or the patient may succumb eventually to the effect of systemic sepsis. So in summary, perforation of intra-abdominal hollow viscous organs can be a surgical emergency, but is not always. Severity of illness and prognosis depends on the degree of free spillage of the contamination. The body's defense response tries to contain the contamination both at the microscopic and the macroscopic level, and success of this mechanism depends on the nature of the perforation and the host response. Thank you for watching.